Assalamu alaikum. Hello, good evening, everyone. My name is Mohammed Alsager. I'm one of the gastroenterologists and transplant hepatologists. First of all, I would like to thank the organizing and the scientific committee for the kind invitation. It's a pleasure to be here. Today, I'll be talking to you about the non-invasive testing in selecting therapies for liver disease. These are my disclosures. So, as we all know, the fibrosis-cirrhosis pathway starts with inflammation. Inflammation adds significant stress to the liver, which will lead to recruitment of inflammatory markers, and that will lead to fibrosis formation and potential cirrhosis and portal hypertension complication. So it is important to stage fibrosis for a prognosis perspective, as currently fibrosis is the single strongest predictor of clinical outcomes in chronic liver disease. It is also important in clinical decision making. For example, someone with advanced fibrosis will need significant monitoring as opposed to someone with minimal or no fibrosis. From a resource allocation perspective, it is also important to stage fibrosis, especially in high endemic countries such as our region. We can't see every mast cell patient or every liver patient. Some patients may need to be seen urgently. We need to triage them. Some other patients may need to be followed in primary care settings. Currently, staging fibrosis is the best endpoint in all clinical trials and researches, and therefore staging fibrosis is important for comparability in all clinical studies that studies liver disease and potential treatment. It also helps with patient motivation. For example, when you tell someone that they have F3 is different than when you tell them that they have fatty liver. It helps the patient to keep them motivated, to be compliant with their medication and lifestyle changes if needed. But the question comes, which modality is better? Is FibroScan better than blood biomarkers, MR elastography versus shear wave? Are they beneficial in low-risk population? Who are the low-risk population? So low-risk population is defined as patients who are non-diabetic, medically free, non-obese with no family history of liver disease with mild alcohol consumption. Before we get into it, we need to understand how do these imaging modalities work. So FibroScan and shear wave elastography work similarly by delivering mechanical vibration through thumbnail and measures elasticity throughout the liver. As we all remember from physics, sound travels faster in hard objects and travels slower in fluid-filled objects. And the liver in normal condition should be fluid-filled. In fibrosis, it becomes hard and stiffer, and therefore the sound travels faster, and that's the high number in FibroScan or shear wave elastography. While MRI works a little bit differently, number one, it creates a heat map that can tell the amount of steatosis across all the liver cells. In addition to that, it delivers mechanical vibration that measures elasticity throughout the liver. Last year, hepatologists from all over the world celebrated the first medication, resmetirom, that helped tackle MASH with significant fibrosis. The inclusion criteria in that clinical trial was liver biopsy with F2 or more. But the question is, shall we biopsy every patient with chronic liver disease? And I guess the better question to ask is, can we? And how good non-invasive testing are. So my talk today will be separated into three parts. Number one, mast cell, a little bit of viral hepatitis, and autoimmune liver disease. So let's get into it. So mast cells affect 25% of the world population. It is accountable for 2 million deaths worldwide. A third of these deaths are female patients. It carries a huge economic impact on countries that are affected. The estimated lifetime cost in Saudi Arabia for mast cell patient comes around $40 billion. And the annual cost in Europe per patient is around 1,200 euros. We're going to see more and more of mast cells, especially with rising epidemic of type 2 diabetes and obesity. So how accurate non-invasive testing in low-risk population in comparison to FibroScan? So this is a study that was published in 2017. It included 922 patients. All of them underwent FibroScan, and the purpose of this study was to see how accurate non-invasive testing in comparison to FibroScan. And what this study showed is that NAFLD fibrosis score, FIB4, APRI, all of them have extremely good specificity and negative predictive value to exclude fibrosis. But what about shear wave elastography? So this is a meta-analysis that was published a couple of months ago in Hepatology. The purpose of this study was to try and see how good shear wave elastography is in biopsy-proven MASLD. As we all know, shear wave elastography is based on ultrasound. There are different manufacturers that manufactures ultrasound machines. And across all manufacturers, 2D shear wave elastography was extremely good with area under the curve of 0.8 in detecting fibrosis, especially when we were getting towards F3 and F4. I would like to highlight something important in this study. This study also tried to unify the appropriate cutoffs across all manufacturers, and this is what they, I want to show it here. Yeah, so this table basically shows the appropriate cutoffs across all manufacturers from ultrasound. So overall, shear wave is another good modality in detecting fibrosis. But what about other imaging modalities? So this is a meta-analysis that was published in 2021. It included around 14,600 patients. And what this meta-analysis basically showed in a nutshell, that all imaging modality, vibration-controlled transient elastography, MR elastography, shear wave elastography, they are all really good in detecting fibrosis. Their area under the curve was high. However, MR elastography and shear wave performed the best, especially when we were getting towards F3 and F4. But what happens when we combine two tests together? For example, a blood biomarker plus FibroScan. And this is the question that this study tried to answer. Sequential combination testing versus single testing. So this is a study that was published in 2019, included 938 patients. They were divided into 2-to-1 derivation and validation study. All patients in this study underwent FibroScan as well as blood biomarker. In the single test analysis, all the blood biomarkers were really good. However, NAFLD fibrosis score was the best. But when it comes to imaging modality, vibration-controlled transient elastography outperformed all the blood tests. In fact, if you use vibration-controlled transient elastography as a second-line testing, it decreases the need for liver biopsy by twofold. And if you use fibrometer, vibration-controlled transient elastography, which is a test that combines the results of the two tests, the fibrometer and the vibration-controlled transient elastography, if you use that as a second line, it decreases the need for liver biopsy even further, 39% reduction. So overall, we have good data that shows that blood biomarkers and other imaging modalities that measures elasticity are really good in staging fibrosis. But what about viral hepatitis? And I promise I won't spend much time here, as this may get covered in other sessions, but I wanted to highlight the data here. As we all know, we still see some cases of hepatitis B and hepatitis C, especially in some areas of the world where access to healthcare is limited. But since the introduction of hepatitis B vaccine, cases have dropped significantly. We still see hepatitis C here and there. Back in 2023, this study was conducted. It's a meta-analysis that took place in Central Africa, 8 countries, 12 sites. And the purpose of this study was to try and compare the appropriate cutoff to detect advanced and significant fibrosis in patients with hepatitis B. This was before the 2024 updated hepatitis B guideline. The WHO back then recommended an APRI of 2 and an APRI of 1.5 as a cutoff for advanced fibrosis and significant fibrosis. But this study, using Udine statistical analysis, suggested that maybe a lower cutoff should be used. And they suggested that an APRI of 0.65 to include much patients with significant fibrosis. And this has led the WHO to fund this study that they based the new guideline based on. So the purpose of this study was to try and see the appropriate cutoff for APRI and FibroScan to guide therapy in patients with hepatitis B. It's a meta-analysis that included 60,000 patients. And what this study showed is that by accepting a lower APRI score, you're only missing 6.8% in patients with significant fibrosis. So you're almost including 93% of patients with significant fibrosis. You're expanding the treatment eligibility criteria, and it's a win-win situation. Remember that these studies were conducted in areas where healthcare access is limited. And that has led the WHO to change their recommendation in the most recent guideline. Instead of 1.5 as their cutoff, they now changed it to 0.5 of an APRI to guide treatment for hepatitis B. Hepatitis C is very well validated. I won't spend much time here. However, transient elastography is the best when it comes to assessing and staging fibrosis. I'll go quickly through autoimmune liver disease. Unfortunately, there are no high-quality data that suggest the epidemiology for autoimmune liver disease, but the incidence ranges anywhere between 4.8 and 42 per 100,000. It's rare in Asia, and in most cases, it is detected at a later stage and is associated with high mortality. This is a study that was published in 2019. It's a meta-analysis that tried to compare FIB4 APRI in comparison to vibration-controlled transient elastography. And what this study showed is that FIB4 and APRI performed poorly in those subset of patients in comparison to vibration-controlled transient elastography. And I think the reason for that is FIB4 and APRI both depends on ALT and AST levels, and they are almost never normal in patients with autoimmune liver disease. But how good vibration-controlled transient elastography in other autoimmune liver disease? So this is another meta-analysis that was published last year. It included 559 patients with PBC, around 400 patients with autoimmune hepatitis, and 150 patients with PSC. And what this study showed is that vibration-controlled transient elastography is extremely good with high area under the curve in PBC, autoimmune hepatitis, and PSC. So currently in autoimmune liver disease, we still need to rely on vibration-controlled transient elastography as opposed to other blood biomarkers. But where does the future take us from here? So I think in the future, we'll be hearing more about spleen stiffness measurements, but we still don't know the appropriate cutoffs for different stages of fibrosis. Another important modality is 3D MR elastography. But we need to know number one, the cost between 3D MR elastography and conventional MR elastography. In addition, the added value of the 3D technology than the conventional MR elastography. As we all know, collagen fibrosis is a dynamic process, and there are some studies that suggest by measuring pro-collagen 3, you can assess and stage fibrosis in liver disease. But again, cutoffs and the exact numbers have not yet been validated. Macrosomal RNA is another potential method that can stage fibrosis. But in the preliminary studies, the area under the curve was extremely low, and it limits its accuracy. In the era of AI, genetic prediction modeling is another promising modality to stage fibrosis, but we need to include ethnicity and age for generalizability. Microbiome, since microbiome now is in every aspect in GI, there are some studies that suggest by adding the age, ethnicity, in addition to the microbiome, you can predict the stage of fibrosis and predict outcomes in patients with chronic liver disease. So in a nutshell, you can't biopsy everyone. There's a huge cost in it. The average liver biopsy costs anywhere between 5,000 and 6,000 riyals, which comes around 1,500 euros. And of course, the cost goes more if it's done inpatient versus outpatients. We also need to keep in mind something, that not all imaging modalities or non-invasive testing are created equally. Some of them are good in certain diseases, some of them don't perform really well in certain diseases. whenever we log in into our social media accounts or even bank accounts, emails, we use multi-factor authentication. And I think when we try to stage fibrosis, we should do the same. We should combine two tests together, two modalities together for better accuracy and less invasive testing for our own patients. And lastly, finding the right non-invasive testing will help us set up an endpoint for clinical researchers and will help us faster drug development, and it will help us conquer liver disease once and for all. Thank you very much for listening.
Thank you, Dr. Mohammed, for this nice presentation. Would like to take just one or two questions, then we'll go for the second speaker. If you have any questions from the audience?
Yes, sure. I have a question. Dr. Mohammed, thank you very much for your presentation. In patient with multiple comorbidities, how reliable I wrote the question here, the current non-invasive scores in predicting the fibrosis?
Overall, non-invasive testing are good in all patients, but the accuracy increases in low-risk population. The area under the curve is still good, and it's still more than 0.8, but it's less accurate when you compare it to patients with low risk.
So you mean here the diabetic population, multiple comorbidities, this is right?
Yeah. Yes.
Yeah. Because what jumped into my mind, Dr. Sakr, while you are doing your presentation, by the way, it is a very excellent presentation and very concise and informative. You know, nowadays you are talking about muscle D under the umbrella of SLD, which is an overarching definition. So we can have under the umbrella of SLD people with muscle viral. So you might have hepatitis B besides the muscle D, and also we can have some autoantibodies besides having the metabolic dysfunction, and even having this autoantibodies may be carrying higher risk for having fibrosis. So what's your advice about interpreting the non-invasive testing in this situation when I have this max? Should I be following the same cutoffs, or this may be a window for going for liver biopsies for such population with this type of max?
Yeah, I think that's a really good question. And I think to answer this question, I think it's best to combine two modalities together. As we have seen, the data has shown that by combining multiple modalities, you're decreasing the need for liver biopsy. So I think by, for example, measuring FIB4 and FibroScan or shear wave elastography, or sometimes combining two imaging modalities is the way to go. There is still no data available that compares, two modalities, two imaging modalities versus single imaging modality. But I think by combining multiple tests together, it increases the accuracy and help your patients.
Okay, thank you.
Thank you.